Welcome to ATCM, the Emergency Medicine channel. Today we are going to discuss about a patient who presented to the ER with neutropenic sepsis.
Okay.
A 64-year-old female was brought to ER with complaints of fever and oral ulcers since the last 10 days.
Okay.
Initial 10-second assessment, patient was conscious, oriented and obeying commands. Her airway was patent, there was no hoarseness of voice, but she was not able to swallow her secretions, so secretions were coming out of her mouth. C-spine were normal, and in oral cavity examination, opening of the mouth was restricted because of some oral ulcers and crusty lesions and some bleeding points, but airway was patent. Other than the secretions, airway was patent. Breathing, her respiratory rate was 24 per minute and saturation was 99% in room air. Circulation, her blood pressure was 110/70 and her heart rate was 124 beats per minute. All peripheral pulses were felt equally and bilaterally.
Okay.
Disability, GCS was E4, V5, M6 and pupils were 2 millimeter reactive.
Anything is abnormal in this first few findings you told?
Tachycardia.
Tachycardia. Okay. Why tachycardia is important here?
Maybe because of anxiety and all, because this patient is sepsis related.
Sepsis. This patient is having, you have told already, neutropenia. Somebody is having tachycardia. That may be the only sign in this patient because he cannot show any inflammatory response to an infection or whatever it is. So tachycardia should be a very important sign in this patient.
Exposure, her temperature was 101.7 degree Fahrenheit and GR base was 178. Adjuncts to primary survey, we already knew that this patient was having neutropenia, so we used extra precautions and then only we proceeded with the adjuncts.
What precautions we have to take as a ER doctor?
Actually, the thing is, we will have to prevent them from getting infected.
Okay.
So, we will have to wear proper new gloves, gown.
Here we are the source of infection, not the patient.
And proper hand hygiene should be maintained. Okay. And if at all we are giving some food and all, it should be properly boiled and all. Okay. And all the IV unnecessary cannulation should be avoided, like central venous catheter, Foley's and all should be avoided. And rectal suppositories, these things should be avoided.
Okay.
Possible isolation facilities, the patient should be examined and kept in
isolation room.
So we have to give a reverse isolation. No, normally isolation means patient is isolated. Here actually we are isolating ourselves from the patient. Okay. We are not giving any infection to the patient. We should be very careful. And
a single dedicated staff should be there for this patient. So this patient blood gas.
So ER is not an ideal place for a neutropenic sepsis. As soon as possible, we have to shift the patient to an isolated place. Otherwise, they will get infection.
Blood gas analysis was done, sir. In that pH was 7.48, PCO2 was 20.9 and bicarbonate was 15.4 with a lactate of 0.8 and creatinine of 2.4. She's having respiratory alkalosis, but it is overcompensated. Maybe because of the renal failure, bicarbonate is low.
So respiratory alkalosis, will it compensate like that in ER? Means in a short duration of time? Overcompensation is possible?
Thing is, bicarbonate is only 15, sir. So maybe that renal failure component is also there.
Okay, so he mostly will have a double acid-base disorder, metabolic acidosis with respiratory alkalosis. In that, respiratory alkalosis is slightly dominating. That's why you are getting a finding.
pH slightly on the
Otherwise, respiratory alkalosis in acute settings, compensation and overcompensation is not possible. If it is a chronic respiratory alkalosis, then only that compensation part will come into picture.
2 large bore IV cannulas were placed and she was given paracetamol at this point of time. Sample history, there is no history of allergy. She is known case of diabetes mellitus with a recurrent history of carbuncles in the past. And she is having history of peripheral neuropathy also. She is diagnosed as psoriatic arthropathy 10 years back and she was on methotrexate 15 mg once in a week. But since the last 1 or 2 years, they are not giving a history of taking folic acid or anything along with that.
Folic acid.
Folic acid.
Normally we give folic acid with methotrexate.
And she is taking OHAs and human atrapid for her diabetes mellitus. Events, patient developed loss of appetite and generalized weakness since the last 2 weeks. Then she gradually noticed oral ulcers and burning sensation all over the mouth, making her difficult to swallow food. And whenever she attempts to swallow food, she started vomiting. And she also developed intermittent fever since the last 6 days. And bystanders also noted some reduced urine output and all, and these things. She was taken to an outside hospital and they diagnosed it as an oral candidiasis and all, but she was referred for further management.
How do you differentiate oral candidiasis from neutropenic ulcers?
Thing is, neutropenic ulcers, their inflammatory response will be low, so the margins will be pale.
Okay. Then oral candidiasis we can scrape and see whether it is coming out or not. Sometimes it can even bleed. Okay. So oral candidiasis, look-wise, both will similarly looking, but here you can scrape and see whether it's coming out or
not. So on examination, sir, patient's head to foot examination, patient was pallor was there, no icterus, clubbing cyanosis, lymphadenopathy or edema. Oral cavity examination, there was multiple ulcers were seen, sir, but there was no curd-like appearance or like candidiasis picture was not there. Some crusts and bleeding and all were there. And other system examination, respiratory system examination, air entry was bilaterally equal. There was no added sounds. And other system examination, we didn't get any findings. So
any occult infection can be there in any of these systems.
Oral cavity, tooth.
Tooth you have to examine. Then perianal areas,
bed sores and all.
Bed sores, but this patient is stable. So, ear infection, then infective endocarditis. So, these are the common things. We may not look into this patient sometimes because they are occult infections which anytime it can come back. Okay.
So we went ahead with the investigation, sir. Her total count was 470.
Total count is 470.
With the neutrophils of 16.7 and there was no
maybe
bands.
Less than 200.
Yes, so the absolute neutrophil count was 79, which is coming as profound neutropenia is there. Her HB was 9.5 with an MCV of 85 and MCH of 29.3. And platelet was 10,000, sir.
Okay, so she has got pancytopenia.
And peripheral blood smear was also showing pancytopenia, and there was no bands or anything. CRP was 255 with a procalcitonin of 4. Her liver function test, everything was normal, and urea was 106 with a creatinine of 2.48.
Okay. What type of renal failure it is?
Buncreat ratio is coming around 20, sir.
Okay.
So renal.
But it is 116. Okay. Urea is 106.
106.
Okay, 106. Even then it is slightly higher.
There might be a component of pre-renal because she was not taking adequate.
She is not able to take by oral, so she will have dehydration. So we have to correct it.
Then her sodium was 132, potassium was 2.6 with a urine potassium of 10, sir.
Okay. What is the importance of urine potassium? Hypokalemia.
We can see whether it is a renal loss or not, sir.
What is a normal urine potassium?
It will be less than 20.
Okay. Less than 20 if the patient is having hypokalemia. Suppose as a normal person we take lot of potassium, urine potassium will be high. Okay. But if the patient is having hypokalemia, then patient should not lose potassium through the kidneys. There it has to be less than 20.
Then pre-op serology, everything was normal, sir. And coagulation profile also was normal. INR was 1.04 and APTT was 33.
Okay.
So this is a case of neutropenia and with a history of fever. And we have a documented temperature more than 101. So it is a febrile neutropenia, sir. We will have to give her neutropenic care. Along with that, we will have to go ahead with the sepsis bundle also. Fluids were started. Anyway, she's dehydrated. So IV fluids were started along with dextrose after checking hyperglycemia. Then already her lactate was on the lower side. So lactate clearance, that part is already okay. Then she was 2 blood culture, aerobic blood cultures were taken. And
so there are 2 types of fluids. Intravascular fluid is there, extravascular fluid is there. If this patient is having dehydration, what type of dehydration this patient is having?
Both are there actually.
Oh. Why you say both are there?
Mostly intracellular.
It is extravascular. Here the patient is having extravascular dehydration because we don't have any sign of intravascular dehydration except for mild urea elevation. So sodium is normal. There is no other features other. But even then, creatinine is slightly elevating. Urea is disproportionately slightly more. Patient can have both, but predominantly this will be extravascular dehydration. Okay. Extravascular dehydration, how do you correct it?
We can give, if we are giving normal saline, almost 60% will be going to the intracellular fluid.
Normal saline, whatever it is, whether it is intravascular or extravascular, it is normal saline or ringer lactate. Okay. But if you want to correct only extravascular, after correcting the intravascular compartment, then dextrose will be a better choice. Okay. Here, ideally, in sepsis, we always try to give normal saline as a first choice.
Then we were antibiotics also were given, sir.
How long you had to continue the fluids? How much fluid was given?
This patient we have started her on 100 ml per hour fluid was started, sir.
How much we have to give? What are the targets? So target has to be fulfilled to terminate the treatment. So when you are starting 100 ml per hour, so in a day it will become 2.4 liters. So how do you assess the fluid status in this patient? How do you know that the patient is going to fluid overload or under treatment?
Urine output.
Intake output chart has to be maintained. Since there is a renal failure, intake output chart has to be maintained. Patient should not go to renal failure. So after giving fluid, what happened to the urea creatinine? That is very important.
It was almost remaining same. So urea became 98 and creatinine is 2.27 that time.
Okay, so it is
slightly improved.
Okay, it has got a renal component also. So we have to wait and watch.
Then since her platelet was 10,000, we will have to arrange for platelet and plan for platelet transfusion also. She is having some oral bleeding manifestations also, sir. And we will have to advise the staff not to avoid arterial pricking and so she was
How much platelet you arrange for this patient?
This patient we can arrange depending on the type of platelets, sir. If it is single donor platelet and all, she might be requiring only one. It can even one pain can increase up to 50,000 and all. Otherwise, if it is pooled platelet, we can arrange 3 to 4. Each will give almost 20 rice. And
why you want to give 4 pints of platelets in this patient?
This patient ideally it is not indicated, sir. If she is having bleeding, platelet is 10,000. If it is less than 20,000 with bleeding manifestations only, we need to transfuse.
I am asking why you want to correct 4 pints of platelet. You told around 10,000 will increase. Why you want to correct it to 40,000 or 50,000 in this patient? What is how many days platelet count can be elevated after a transfusion?
Normally, if our body is producing, it will last up to 7 days. But if you are transfusing, only 24 hours.
So it is unnecessarily we are giving 4 pints or 5 pints. It is not going to help the patient. If you are going to do a procedure like some intervention, then 4 pints can be given and you can treat the patient with that procedure. But here only you want to increase the count somewhere around 20,000. That's all. So 1 or 2 pints will be more than enough to maintain that level, or a single donor will be enough. Single donor is costly, so we don't prefer single donor unless until we have a long-term treatment plan.
requirement. And she was started on Piptazar. So it is for anti-pseudomonal coverage. So in neutropenic sepsis, there is high risk for infection with gram-positive, gram-negative, and pseudomonal infection. High risk is there. So either we will have to start on Piptaz or ceftazidime or cefepime should be started, sir. And if at all this patient is having any soft tissue infections or any indwelling catheters or anything is there, or if this patient is having some history of Clostridium difficile infection, or this patient is having any hypoxia, renal failure, then elevated liver functions and all, that means some other complications along with that, then we will have to start on an MRSA coverage also.
What MRSA coverage you will give here?
This patient already renal failure is there, so better to give linezolid.
Okay.
But the platelet is also on the lower side.
So we have to find another drug which can, or vancomycin itself, adjusted dose, or a new drug which cover MRSA should be given, because platelets are very low. Linezolid may sometimes create problem.
Daptomycin.
Daptomycin. Okay.
Then that should be done, and then for the oral cavity we should give chlorhexidine mouthwash and everything should be given, and proper well cooked food, if at all she is tolerating, we will have to give that, and if she is not able to tolerate that, we can start on clear liquids. If that also fails, then we will have to plan on giving TPN also. Then
TPN. What is TPN?
A total parenteral nutrition.
When will you give TPN?
That is indicated if there is more than 10 days of not taking food.
TPN is not a good choice in any patient.
That itself
cannot
can
take
cause
at all. Only we should advise for TPN, because that has got its own complication, and we are bypassing a normal physiology in a patient. If the patient is able to take, even with oral ulcers, we should try to give orally only. Then additional partial parenteral therapy can be given, like dextrose or some amino acids can be given through peripheral line.
Then this patients, the cause of neutropenic sepsis is because of the methotrexate. So we the precipitating factor might be an old age, that means more than 60 years, and she was not taking folic acid, and there is renal failure also. So these might be the precipitating factors. So we will have to supplement with folinic acid. Active form of folic acid should be given. So we will have to give at least 1 mg per kg every 4 to 6 hourly. We will have to give the
Normally we give 25 milligram QID
dose should be given.
IV is available.
Then
oral also
available. This patient we are giving IV, sir. Then colony stimulating factors also should be given, sir.
What colony stimulating factor we are giving?
We are giving filgrastim is given.
Granulocyte. Okay.
Dose? 300 microgram once in a day we are giving.
Subcutaneous. Okay.
And that should be given daily to a maximum of 14 days or till the
Which all neutropenia this can be given for colony stimulating factors?
This can be given for post chemo.
It's mainly indicated in drug induced neutropenia, not in other like you have a patient who is having myelothysis anemia, myeloproliferative disorder, myelosuppressive disorder. It may not work, but in drug-induced neutropenia, it may work. Okay, so they are indicated only in drug-induced neutropenia. So this case is assumed as a drug-induced neutropenia. So in case of neutropenic sepsis, if the patient is stable and if this patient is having only neutropenia without much fever or any, if the patient is stable and can be discharged home, we can give oral tablets and discharge home, like amoxicillin can be given. But this patient should be reviewed within 24 hours and we should be monitoring. If this patient is having any renal failure, hypotension or any indwelling catheters or any liver failure, and if the patient is
having a malignancy and all, we will have to check all these things, and we will have to plan on an IP admission and start on MRSA coverages also. And even after 7 days of treatment, this patient, and if the blood culture is coming negative and we are not getting a source, then we will have to start on antifungal coverage also. So if we know lung as a source, we will have to give voriconazole, or otherwise classically we will have to give echinocandins as an antifungals for neutropenic sepsis.
Now what happened to this patient afterwards?
This patient was admitted to our ICU. This patient already has a history of fever since the last 10 days, but she is having renal failure, and also she requires pseudomonal coverage, MRSA coverage, and antifungals also, sir.
So what are drugs are given now?
So piperacillin, tazobactam, then colibitor, and she started on fluconazole.
Colibitor is
PCP quatermax.
okay. So piperacillin, tazobactam, how do you adjust the dose?
Because depending on the creatinine clearance, it should
So
be
you have
adjusted.
to correct according to creatinine clearance. Okay. So that is given.
Yeah.
Antifungals?
Fluconazole is given.
Okay. How much dose?
400 stat and 200 milligrams.
Okay. What do you have to look when you are giving
Liver
okay. Liver function has to be monitored. Okay.
Then proper input-output charting and was done, and feeding also, and electrolyte monitoring also was
Okay.
done.
Should we do bone marrow in this case?
This patient, we know the cause, sir. It is
Mostly.
drug-induced, and since the peripheral blood smear doesn't show any blast or anything, then we can
If
wait.
there is a blast in peripheral smear, will you try GMCS?
No, sir. We will have to get the diagnosis.
So if you are seeing peripheral blood smear, any blast cells, better to avoid colony stimulating factors. Then you need a proper diagnosis before giving colony stimulating factors from our side. Okay. Anything else?
Sir.
Thank you.